Hello, thank you for joining the ERJ Podcast. My name is Dr. Don Sin. I'm the Deputy Chief Editor of the European Respiratory Journal. Today I'm joined by Professor Stephen Nathan to discuss his latest paper entitled Inhaled Treprostinil in Pulmonary Hypertension Associated with COPD, Perfect Study Results. This paper is published in the June issue of the ERJ. Dr. Nathan is currently the Medical Director of Inova's Advanced Lung Disease Program and a Professor of Education at the University of Virginia. He has published more than 500 papers and is a worldwide leader in the study of advanced lung diseases. Good morning, Steve.
Thank you, Don. Thank you for inviting me, and it's a pleasure joining you here today.
Could you provide a brief summary of the PERFECT study and its main findings?
And first of all, the first lesson is never call a study the perfect study, because it's kind of tempting the fates. And as can be seen from the article, unfortunately, it was a negative study at the end of the day. But just to provide a little bit of background, COPD, obviously very common disease condition. Pulmonary hypertension does complicate the course of patients with COPD. Anywhere upwards of 50% of patients who listed for transplant with COPD will have pulmonary hypertension. And we have many different drugs approved for group 1 PAH, with a lot of interest in, can these drugs be used successfully in patients with group 3 pulmonary hypertension, namely pulmonary hypertension related to lung disease? So there was the very successful INCREASE study, which looked at inhaled treprostinil in pulmonary hypertension associated with interstitial lung disease, and that subsequently led to the approval of this drug for PH-ILD. At the same time that the INCREASE study was going on, the sister study, or the bookend study to that, was the PERFECT study, looking at inhaled treprostinil in COPD with associated pulmonary hypertension. A little bit of a different design. We used a PVR cutoff of 4 or greater, MPAP 30 or more, and the primary endpoint at the end of the day was going to be the 6-minute walk test. The study was a little bit shorter in duration. I think it was 12 weeks. So it was initially a crossover design, but then due to interim analysis, we converted it to a typical double-blind randomized control study without the crossover. And at the end of the day, there were 70 plus patients in each arm. And unfortunately, based on the primary endpoint, it was a negative study in terms of impacting the 6-minute walk distance. So many lessons from this study in terms of hopefully future clinical trial designs. And certainly one of the lessons is that not all group 3 pulmonary hypertension is the same.
So you mentioned the INCREASE study that was conducted in patients with interstitial lung disease and pulmonary hypertension, where the inhaled treprostinil worked, whereas in the PERFECT study, in which COPD patients with pulmonary hypertension were assessed, the drug did not work. Why do you think there was a discrepancy between the two studies?
There's no smoking gun that I can say this is the reason. I think clearly fibrosing ILD, which was INCREASE study, and COPD are very different, but they do share the commonality of being complicated by pulmonary hypertension. Despite this being a negative study, I think that there still is a subgroup of patients with COPD who can benefit from therapy. It's just a question of trying to identify them and designing the appropriate clinical trial. As I think about clinical trial design, and I think this is very apropos, both INCREASE and COPD, there are many elements that have to line up correctly in terms of getting it right. You have to have a drug that works, correct route of administration, correct duration of the clinical trial, correct endpoints, and the correct patient phenotype. And I think that there is a phenotype out there with COPD who have pulmonary vascular disease who could still be responsive to therapy. And those are some of the lessons hopefully we can glean from the PERFECT study, is what went wrong, what can we learn, how can we next best design the next PERFECT study, PERFECT 2, in terms of what's the next drug or the same drug that we can try, and what are the lessons learned. I have to go back to the INCREASE study, because prior to INCREASE, there was the RISE IRP study, which looked at riociguat for the exact same condition, PH associated with interstitial lung disease. That was not only a negative study, but it was a harmful study as well that was stopped early by the DSMB. And so we moved on from that, and then we did the INCREASE study, which was unequivocally positive. So I don't think as a community, we should be put off by studying pH associated with COPD. It's kind of like when you get off a horse, if you fall off a horse, you get back up and you start riding again. I would encourage folks, and especially the pharma biotech community, to really look at this, because if we do identify the phenotype and if we do identify the right agent given the right way, there's potentially a huge group of patients who could benefit from this.
Very good. Can you tell us a little bit about the drug itself, treprostinil? What is it? And was there evidence of target engagement in the COPD lungs?
A very good question. It's a prostacyclin derivative. It targets a number of different prostacyclin receptors and works typically as a vasodilator. That's its main modality. It has some antiplatelet properties. But actually what's interesting as well is that it does have potential antifibrotic properties. And one of the signals that came out of the INCREASE study was that the group that got drug, especially the IPF population, appeared to have better outcomes at 16 weeks in terms of the FVC. And this, of course, is post-hoc hypothesis generating. And this is currently being tested and studied through the TETON study. The TETON study is looking at the same drug, inhaled treprostinil, purely for its antifibrotic effects, totally agnostic to the presence or absence of pulmonary vascular disease. So there are other properties aside from it being totally a vasodilator. So in terms of target engagement, very difficult to know. And this comes up with all inhaled medications. And I think that beyond COPD that are being studied for ILD and IPF, you can do PK measurements of inhaled drugs, but that really doesn't tell you about target engagement within the lungs, because if you get a lot of nasopharyngeal deposition, you're still going to have some PK output from that. So even though we can look at drug levels, we don't know where the drug is getting absorbed from, if it's from the upper respiratory tract or the lower respiratory tract or the back of the throat.
I know the study was relatively small in sample size, but were you able to explore subgroups in which the drug may work, which may inform future therapeutic clinical trials?
When we got the negative results, we did a little bit of a deep dive trying to see, is there a specific target population that might be more or less responsive? And in actual fact, we had developed a paper and submitted it to ERJ about this post-hoc analysis, which some of that we incorporated within the primary publication, but there are some cursory lessons from that. The group that appeared to perhaps be a responsive group, no surprise, were patients with MPAPs, mean pulmonary artery pressures greater than 40, with FEV1s greater than 40%. A group that seemed to be at higher risk of a bad outcome were patients with DLCOs less than 25% are predicted. So that makes me think of the DL as a surrogate for the pulmonary vascular bed. Is there an inflection point where you've had so much destruction of the pulmonary vascular bed that giving a pulmonary vasodilator might not be a good thing? So there are these lessons that can be teased out from a very robust data set at the end of the day. Hopefully those kind of nuances will help the design or inform the design of future such studies.
In view of the PERFECT study and others, how should COPD patients with pulmonary hypertension be treated today?
I would firstly say that they should be best managed at expert centers. I think that a big danger is people making the assumption that, well, we have these drugs for pulmonary hypertension. I have a patient with COPD. I'm going to put them on this drug. Clearly, we showed that that should not be the case from the PERFECT study. The question goes to the whole conundrum of when is it group 1 pulmonary hypertension with concomitant or comorbid COPD versus when is this group 3 pulmonary hypertension and the pulmonary hypertension is all due to the COPD. And it's a spectrum, and it becomes a judgment call in terms of trying to balance the extent of the parenchymal lung disease with the severity of the hemodynamics. And that's why I think these patients are best managed. If there's any consideration to therapy, then they're best managed at an expert center.
Thank you. Any last words on the PERFECT study or regarding pulmonary hypertension associated with COPD in general?
It's obviously disappointing to all the stakeholders, especially the patients that this study was negative. I think the big message to me are to investigators and once again to the pharmaceutical community in particular to go after this in perhaps a more informed fashion than we did from PERFECT. Maybe PERFECT provided a foundation for future such studies. if you look at the literature, most of the studies in COPD PH have been small, single center, retrospective. They haven't been very well done, but there's kind of a messaging from all those studies that there is benefit that can be seen in some of these patients. But we obviously need to study this rigorously in the context of phase 3 clinical trials. I think that we've given so much attention to the airways in COPD and haven't given enough attention to the vasculature. And I think that there is a link between what happens within the vasculature and the genesis and progression and symptoms and outcomes of patients with COPD. So I think we really should focus more on the pulmonary vasculature in patients with emphysema in COPD.
Well, on that note, thank you, Steve, for joining us today. It's a tough topic, but I think you explained it very well.
I appreciate the opportunity just to bring attention to not so much the paper, but just, as I said at the end, to the vasculature in COPD.
Oh, very much so. Yeah, I think it's a great study. Hopefully you'll be able to do perfect too.
I hope so. As I said, we went from rise IP to increase. And I think, the lesson is we can do the studies. Let's do it. Next go around and we'll try again.
Well, there's certainly a clinical need. Well, thank you again, Steve.
Thank you, Don.
Professor Nathan's paper, Inhaled Treprostinil in Pulmonary Hypertension Associated with COPD, Perfect Study Results, is now available on the ERJ website, erj.ersjournals.com. Thank you.